Hello everyone and welcome to my YouTube channel. This is Dr. Naz and today I am going to discuss about chronic obstructive pulmonary disease, which include two conditions, emphysema and chronic bronchitis. COPD refers to irreversible obstruction of the airways and it is characterized by progressive airflow limitation caused by airway and parenchymal inflammation. Asthma is not included in COPD because it is reversible condition and it is reversible obstruction. So the risk factor of COPD include smoking, alpha-1 antitrypsin deficiency, occupation, example coal miners, cadmium exposure, chronic asthma and cannabis smoking. Cigarette smoking is the most important risk factor for COPD and it is unusual to develop COPD with less than 10 pack years of cigarette, and the 1 pack year is equals to 20 cigarettes per day for a year. So emphysema is the permanent enlargement of the air spaces distal to the terminal bronchioles and accompanied by destruction of their walls. You can see in the picture the alveoli which is affected by emphysema is dilated, and there are two types of emphysema, centriacinar and panacinar. Centriacinar affects the upper lobe, however panacinar involves the lower lobe and is most severe at the bases of the lung. So centriacinar is the most common type of emphysema. It affects the heavy smoker and is associated with chronic bronchitis. However, panacinar is associated with alpha-1 antitrypsin deficiency. So chronic bronchitis is persistent cough with the sputum production for at least 3 months in 2 consecutive years. So you can see in the picture, due to persistent inflammation, there will be increased number of mucus gland and there will be a smooth muscle hypertrophy. This will lead to decreased bronchiolar diameter. Increased number of mucus gland will produce excessive mucus which will be secreted as a sputum. So there will be chronic cough and sputum production. So the age at which the disease usually presents is over the age of 40 years. It will present as chronic cough and sputum production, especially in chronic bronchitis, dyspnea which will be worsened by exertion in both conditions, intermittent exacerbations in advanced stages, and weight loss especially in emphysema. There will be increased anterior-posterior diameter of the chest, which is known as barrel chest. Breath sounds will be decreased with hyper-resonant note on percussion. Increased expiratory phase, rhonchi and wheezes will be there. Decreased diaphragmatic excursion, weight loss, cachexia, headache due to hypercapnia from carbon dioxide retention. This is a picture of barrel chest. Blue bloaters versus pink puffers. So blue bloaters is predominantly bronchitis, however pink puffer is predominantly emphysema. In bronchitis the patient will be overweight, there will be cyanosis, that's why it's known as blue bloaters, and cyanosis is due to hypercapnia and hypoxemia. The hypercapnia will result in increased partial pressure of carbon dioxide and hypoxemia will result in secondary polycythemia. So there will be increased hematocrit as well. There will be no distress and there will be no use of accessory muscles of respiration. Respiratory effort is normal or slightly increased. However, in pink puffers, which is predominantly emphysema, the individual will be thin and there will be no cyanosis. Breathlessness will be there and the use of accessory muscles can be seen. Tachypnea with prolonged expiration through pursed lips is present and there will be normal partial pressure of carbon dioxide. So pulmonary function tests are the diagnostic test of choice and it will show obstructive pattern. So there will be increased residual volume and total lung capacity. However, there will be decreased in forced expiratory volume at 1 second, or FEV1 to FVC ratio will be decreased. Also there will be decrease in peak expiratory flow. Next is methacholine challenge test. Methacholine is a bronchoconstrictor and when it is given in COPD, there will be no decrease in FEV1. However, in asthma, there will be decrease in FEV1 of more than 20%. So basically, methacholine challenge that differentiates between asthma and COPD. There is no difference in COPD because there is permanently involvement of the air spaces. So bronchoconstrictor will have no effect on the diseased alveoli or diseased bronchi. DLCO is diffusion capacity of carbon monoxide, and it determines how well oxygen passes from alveolar space of the lungs into the bloodstream. In obstructive lung disease, the decreased DLCO is seen in emphysema. So we can say that if there is an obstructive pattern on pulmonary function test plus there is decreased DLCO, then the disease is emphysema. If there is obstructive pattern on pulmonary function test plus methacholine test is negative with normal DLCO, it is chronic bronchitis. However, obstructive pattern on pulmonary function test with positive methacholine test and normal DLCO, it is asthma. So DLCO is only decreased in emphysema. Also, there is another condition which is a restrictive lung disease, and there will be decreased DLCO in that restrictive disease, which is interstitial lung disease. Other investigations may include complete blood count, which will show increased hematocrit, and it is due to secondary polycythemia from tissue hypoxia. So there is decreased oxygen in the tissues, which will be detected by kidney, and it will start producing erythropoietin, which result in secondary polycythemia. In ECG, there will be right atrial hypertrophy and right ventricular hypertrophy. It is because the lungs are so much hyperinflated that the right ventricle has to work harder to push the blood towards the lungs. So that's why they will undergo hypertrophy. On chest x-ray, there will be hyperinflated lungs. And how do you see hyperinflated lungs on chest x-ray? So you will count the ribs on the x-ray. Anteriorly there will be 6 ribs visible and posteriorly there will be 8 ribs visible. So if these amount of ribs are visible, then they are hyperinflated lungs. Due to hyperinflated lungs, there will be flattened diaphragm, and because of the same reason, that is hyperinflated lung, it will lead to a small tubular heart. Why lungs are hyperinflated in COPD? It is because there is a decrease in the elastic recoil of the lung parenchyma, and there is dynamic air trapping during successive breaths. So it will lead to hyperinflation, and because of this hyperinflation there is increased anterior posterior diameter. So basically the hyperinflation is giving all these pictures. How are we going to manage it? Yearly influenza vaccine and 5-yearly pneumococcal vaccine is very important. To improve the mortality rate, smoking cessation is very important, and long-term oxygen therapy is also very important. It should be used for a minimum of 15 hours per day. It provides more benefit if used more than 20 hours per day. What are the indications of long-term oxygen therapy? If partial pressure of oxygen is less than or equal to 55 millimeter of mercury, oxygen saturation is less than or equal to 88%. The ideal target of partial pressure of oxygen is more than 60%, and the oxygen saturation is more than 90%. So symptomatic treatment does not improve survival. However, we give bronchodilators, which are the first line therapy for symptomatic relief. We can give anticholinergic agents including short acting ipratropium and long acting tiotropium. We can give short acting beta agonist and long acting beta agonist as well. However, long acting anticholinergic agent, example tiotropium, decreases exacerbation, hospital admission and respiratory failure, so it is better than ipratropium or LABA as monotherapy. Inhaled corticosteroid reduce the frequency and severity of exacerbation, and it is more effective when combined with long acting beta agonist. Indication of inhaled corticosteroids are severe disease, that is FEV1 less than 50%, and patients with more than or equal to 2 exacerbations per year requiring antibiotics or oral steroids. So they will be a candidate for inhaled steroid therapy. Antibiotics can also be used. Daily azithromycin decreases exacerbation. However, it is not yet routinely recommended. Pulmonary rehabilitation and surgery is the last resort, which is the lung transplant. Prognosis is inversely related to age. So the greater the age, the worse is the prognosis. And prognosis is directly related to FEV1. So the higher the FEV1, the better the survival. Acute exacerbation of COPD is characterized by an increase in symptoms and deterioration in lung function and health status. The physical examination will reveal tachypnea, an accessory muscle used for respiration, pulsus paradoxicus, and cyanosis. So pulsus paradoxicus is fall in systolic blood pressure of more than 10 mm of mercury during inspiration, and it will occur in acute exacerbation of COPD. Treatment of acute exacerbation includes oxygen therapy. 24 to 28% oxygen should be used. High concentration should be avoided because of respiratory depression and acidosis. Target should be partial pressure of oxygen should be more than 60 mm of mercury, and saturation should be kept between 88 to 92%. Second is bronchodilator. Anticholinergic agents, example ipratropium, are the first line agents, plus short acting beta agonist albuterol can be given. Steroids, either oral or IV, can be used. Oral should be given for 10 days, and if you are giving IV, then for 72 hours in severe cases. Antibiotics should also be given along with bronchodilators and inhaled corticosteroids. You can give amoxicillin, macrolides, cephalosporins, and quinolones. None of the antibiotics is superior over the other, so you can give any of the above. Non-invasive ventilation should be started as soon as possible in patient with moderate to severe dyspnea. It is not useful in patient who cannot protect their airways. If initiated early, it will reduce the need for endotracheal intubation, treatment failure, and mortality. The indications are when the patient is persistently tachypnic and patient is in respiratory acidosis, that is less than 7.35 pH, and when partial pressure of carbon dioxide is more than 45 mm of mercury. So this is the end of the lecture. I hope you learned something from it, and if you do, please do like my video and subscribe to my YouTube channel. Share my videos with your friends, and thank you so much for watching.